Welcome to Samaritans Purse International Health Forum today. We're so thankful that you're joining us. We hope you participate in the conversation today. I just want to remind you that you can chat with us in the chat box beside the video. Before we begin today, let us just open up in a word of prayer. Lord God, we're thankful for today. We're thankful for the opportunity to come and learn. We thank you for Dr. Mabula, who has so graciously given up her time and effort to share with us, and we just pray that you would bless our time today. In your name we pray. Amen.
Amen.
All right, well, we're very excited to have Dr. Linda Mabula with us today. She is speaking to us on the topic of non-communicable diseases during humanitarian emergencies. And Dr. Mabula has a significant amount of experience. And so I'm just going to give you a little introduction on her. She holds a BS in biochemistry and molecular biophysics from the University of Arizona. She's a doctor with a concentration in global health and an MPH from Johns Hopkins School of Medicine, and she has a concentration in health, crisis, and humanitarian emergencies. She currently serves as public health and infectious disease advisor with OFDA and USAID, and she's also on faculty in the Department of Medicine at Johns Hopkins and is the co-principal investigator of Ghana Access and Affordability Program. She has quite a bit of experience, including the Office of HIV and AIDS at USAID, where she has provided technical assistance to countries such as South Sudan, DRC, Mozambique, and Burundi. And she has been the medical director for Samaritans Purse health programs in Haiti. She's been the chief medical officer to our SP response in the Philippines. SP's Ebola response in Liberia during the summer of 2014, and she's been the health advisor and deputy DART team leader for the USAID and OFDA and the Ebola response in Guinea, acting senior humanitarian advisor for OFDA in Guinea, and senior program manager for Samaritan's Purse European refugee response in Greece. Obviously, a wealth of experience you're coming with us to today. So before you begin, I did forget to announce that if you're on our email list and you're interested in receiving CME credit, the form and instructions will be in our follow-up email, and we'll include a link to this recording. So I just wanted to remind everyone of that. With that, Dr. Mabula, will you begin your presentation, please?
Thank you, Beth. The title of my presentation today is Non-Communicable Diseases During Humanitarian Emergencies. Let's go to the next slide, please. So briefly, NCDs, I will refer to non-communicable diseases as NCDs for the rest of the presentation. So we do know that NCDs are the leading cause of mortality worldwide. And it's estimated that about 38 million deaths are caused by NCDs. And the four main diseases that cause these deaths are cardiovascular diseases, diabetes, chronic respiratory diseases, and cancer. Next slide, please. We also know that 80% of these deaths occur in low and middle income settings. And this has been really interesting because for the longest time, the majority of deaths in low and middle income countries were actually caused by infectious diseases or communicable diseases. So we're seeing this shift called the epidemiologic transition, which I'll describe in a little bit. But we're also seeing that NCDs actually contribute to 54% of global disability adjusted life years, so DALYs, and the majority of this burden actually affects developing countries. Next slide. So this is a graph that I obtained from WHO, and it's from 2008. And it basically depicts the proportion of deaths that are caused by injuries, which is represented in green. Red, you're seeing deaths from NCDs, and in yellow, you're seeing deaths caused by communicable, maternal, perinatal, and nutritional conditions. And if you look to your left, looking at basically males, we're still seeing that the majority of deaths are actually caused by NCDs, regardless of which part of the world you're in. So on the far left, you have different WHO regions. So Afro, which is the first column, America, which is the second column, EMRO, which is Eastern so the Middle East, and then you have Europe, but also Southeast Asia, and then the West Pacific region. So regardless of which region of the world you are in, the majority of deaths are actually caused by NCDs. So then looking at the far right, basically still looking at within males, we're seeing it basically divides country based on income. So you have low income countries, lower middle income countries, upper middle income countries, and high income countries. And regardless of income, we're still seeing the majority of deaths actually caused by NCDs. In low income countries, we're actually seeing a little bit more deaths caused by infectious diseases and maternal, perinatal, nutritional conditions. But I guess this doesn't really apply to males because we're really looking at communicable diseases and not maternal and perinatal. And looking at females, it's a very similar trend. And this was back in 2008. There's been more data that's been collected on this. So next slide. So as mentioned, I talk a little bit about the epidemiologic transition and the emergence of NCDs as being the major cause of death among populations living in different parts of the world. So due to phenomenons like globalization and urbanization, there's been a change or a shift in lifestyle. So diets have changed, physical activities have changed, people are more sedentary. There's been an increase in the use of tobacco, and this all causes a rise in blood pressure, a rise in rates of high cholesterol, obesity, and diabetes, leading to an increase in mortality and morbidity. Next slide, please. So in addition, there have been a lot of different changes in society, looking at some of the socioeconomic structures that kind of underlie physical activity and nutrition changes. So because our societies are more industrial, there's less physical activity among folks. We sit in front of computers a lot. We watch television. There's a higher availability of cheap processed foods. So there's foods now have high fat, high sugar content. There are also changes in household technology. So you don't have to, spend a lot of time getting food because, there are stores close by, you can refrigerate food. In terms of food preparation, there's like electricity and appliances. So this actually leads to less physical activity as well. And as mentioned before, there's been this dramatic change in leisure activities for both adults and children. So we spend a lot more time watching television in front of computers, but also in terms of imaging and marketing that's brought to each household, that also alters consumption of the different types of food that we have. Next slide, please. So these are a couple of examples. So we're eating a lot of foods that are canned, that have a high content of cholesterol and fat. Next slide. But also, there's a lot more availability of foods at grocery stores, and we're not eating fresh food anymore. Next slide. Also, back in the day, people would work in the field a lot more. We're seeing, as I mentioned, people sit in front of computers all day or watching television. Next slide. And finally, instead of walking, we spend a lot of time in vehicles and doing less physical activity. Next slide. So this is data from Dr. Murray, who's from the University of Washington in Seattle. And he's really been working on the global burden of disease study, looking at kind of changes in the global burden of disease worldwide. So back in 1990, if you look at the proportion of deaths that were due to cardiovascular disease compared to infectious and parasitic diseases, you saw that among men and women, there were a lot more deaths that were actually due to infectious causes. And on the left, it's basically death per 1,000, sorry. And if you go to the next slide, comparing 1990 to 2020, he basically projected a 125% increase in the number of deaths that were actually caused by cardiovascular disease, and a 141% increase in the number of deaths caused by cardiovascular disease among women. So we're seeing this trend, upward trend of deaths caused by cardiovascular disease in sub-Saharan Africa. Next slide, please. And also, this slide looks at the projected changes in terms of cerebrovascular disease mortality. And there's a very similar trend among men and women when you compare, the proportion of deaths caused by CVD in men and women. Next slide, please. So briefly looking at diabetes, so this is this was actually taken from a study that was done by Wild et al. And looking at the global prevalence of diabetes and looking at projections of diabetes in 2030. And we're seeing similar trends. So an increase in the prevalence of diabetes from 2000 to 2030. And it's really worldwide, whether it's upper income countries like the US or low and middle income countries in sub-Saharan Africa and Asia. You're seeing the similar trend of an increase in the prevalence of diabetes. Next slide, please. And how does that relate to humanitarian emergencies? So by definition, we know that humanitarian emergencies or crises result from multiple causes, such as conflict, natural disasters. Sometimes we have humanitarian emergencies that are a result of epidemics or pandemics, and this was the case, with Ebola in West Africa, but also due to complex emergencies, such as, the earthquake in Haiti. And there are different types of emergencies overall. So there's acute onset or rapid onset caused by disasters, so as a result of an earthquake or flooding. Slow onset, which can be caused by conflict. And you have protracted crises, and this is the case in places like Syria and Iraq, where you have a conflict. The conflict in Syria, for example, started about 6 years ago. So you have this humanitarian emergency that really persists for a long time. But also looking at post-crisis. So in the case of the Ebola response, for example, there has been a lot of work that's been done on rebuilding health systems after the humanitarian emergency. So you have humanitarian emergencies that pose this stress on health systems, or that can be caused by a natural disaster. And there's a need to actually look at how that affects both health systems, but also how to implement programs for NCDs. Next slide, please. So NCDs and emergencies. So let's make the link between an increase in the prevalence of NCDs and how this affects humanitarian emergencies. So we know that it's NCDs are rising as a major public health issue in humanitarian settings because a lot of these disasters actually affect low and middle income countries. And we know that NCDs have characteristics that make people more vulnerable during an emergency. For example, they don't have access to their drugs anymore. There's a disruption in terms of services that are provided. Health systems are collapsing. There was a study done by Dr. Heyman at the London School that actually showed that there's an increase in the risk of NCD complications during an emergency. And he basically demonstrated that both heart attacks and strokes may increase up to 2 to 3 times. They're more common than in normal pre-emergency circumstances. So even though there's limited data on how emergencies affect or kind of affect the epidemiology or the burden of NCDs, we're actually there is some data coming from some countries that basically suggests that there's an increase in the risk of NCD-related complications. Next slide, please. So as you know, so NCDs are basically chronic diseases, so they require ongoing provision of treatment. And during an emergency, there is often disruption of services, as well as reduced access to treatment, leading to interruption of treatment, therefore causing acute exacerbation of a chronic disease or an increase in the presence of complications. Next slide, please. And as I mentioned, there's very limited evidence base because it's really challenging to actually collect data during an emergency. And for those of you who have been involved in various responses, you know how challenging it is to actually implement programming. So just think about how challenging it is to collect data during an emergency. It typically happens much later. And so there was a systematic review on the effectiveness of interventions for NCDs. And basically, there have only been 8 studies that have been published in the past 35 years on how NCDs, how humanitarian emergencies affect NCDs. That's a very, very small number, and that there needs to be more data collected. There needs to be more evidence produced. There needs to be more papers that have published on this topic. Next slide, please. So, in addition to some of the challenges that I mentioned, when you're actually implementing programs, it's going to vary based on geography, so which country you're in, based on the amount of resources that you have prior to the emergency, but also the level of health systems, healthcare personnel. So as you're kind of implementing programming, it's going to really change based on the factors that I described above. But because it's also really challenging to implement when you don't have data on epidemiology and emergency settings. So what type of programming do you want to implement? Should it be targeted, for adults? Should it be obviously for NCDs, yes, but should it be targeted, with older adults, males, females? We don't have a lot of data when you're actually starting to implement a program in the context of an emergency. There's limited data on the burden of disease. Should you focus on hypertension? Should you focus on diabetes? Should you focus on, asthma or COPD? There's often very limited data on the burden of disease in specific countries, the availability of services, whether or not there is follow-up care that's available. Should you be referring patients to hospital XYZ? Is that hospital even open? And also, how sustainable are your interventions? So when you're actually providing, setting up mobile clinics or providing, supply chain or supporting supply chain, the infrastructure for supply chain, or actually providing drugs for patients, how long are you going to be able to do that because of the fact that, NCDs are chronic illnesses? So these are things to think about as you're actually implementing programs for NCDs. Next slide, please. And here's an example of an assessment this was published in a paper that was written by ICRC, and these are questions to think about as you're doing an initial assessment. Because really, you really want to implement programs that are focused on integrated care and focus on primary health care. But here are questions to think about as you're implementing or planning to implement a program. Number one, what are the existing capacities of the local health system? You don't want to duplicate what's already there. Which NCD should you address? Should you, again, as I mentioned before, focus on hypertension, diabetes, cardiovascular disease? These are things that you need to think about as you're doing an assessment. Who is a target population? Are you targeting the elderly? Are you targeting males, females? What kind of interventions are needed to ensure continuity of care? Which algorithms or guidelines to use? And this is really important because, and I'm going to talk about existing guidelines that basically inform us on what types of medications you need to use as you're implementing a program. But it's really important to actually look at national guidelines in country and which drugs are already available, because as you're working with healthcare providers, you don't want to introduce new drugs that they've never been exposed to, but you also want to ensure that drugs that are being used are available once your program scales down. So number 6, which medications should be integrated in the basic essential drug list? What are the ethical implications? And this is really important. Do you dialyze during an emergency? Do you treat cancer? And these are questions that have come up over and over again. How do you ensure accountability to patients? How do you monitor your interventions? And what do you do beyond provision of health services for classical NCDs? So these are things to think about as you're implementing or planning on implementing a health program in the context of an emergency. Next slide, please. So there are very few guidelines that tell the humanitarian community how to program health interventions, specifically after an emergency for NCDs in particular. There are a lot of guidelines on communicable diseases, reproductive health, but there are very limited guidelines on NCDs. So Sphere, which is our standard, provides minimum standards for health and for other sectors, initially did not have any information on NCD treatment. And just recently, Sphere was revised to include a section on NCDs, and I actually helped helped revise that section. And it's available online. It hasn't been completed yet, and there's still a lot of evidence that needs to inform what's actually in the guidelines. But there are other resources out there. So the World Health Organization has 2 existing guidelines. One is called the Package of Essential Non-Communicable Disease Interventions for Primary Healthcare in Low Resource Settings. So that's a very good resource to use in the context of emergencies and in countries that are low income. So if there is no emergency. There is another resource called NCDs During Emergencies that WHO also developed. It's a 2-pager. It provides you with a brief overview of what you need to do and a list of drugs to consider as you're implementing programs. MSF is in the process of developing clinical guidelines for NCDs for humanitarian settings. It's a draft, but it's available online. It's a very useful resource. And the last resource that one of the other resources that is available is called the UN Interagency Task Force on NCDs. Next slide, please. So USAID, so OFTA has an existing resource online. So there are guidelines for proposals where there is an outline of what should be considered when you're actually applying for an OFDA grant. And there are several subsectors, and NCDs is one of the subsectors. So OFTA does support NCD interventions occurring in humanitarian emergencies, especially in countries that have a really high burden prior to the emergency. So this section also includes guidance on things like mental health, as well as trauma. So it's online. I would also look at the OFTA proposal, OFTA guidelines for proposals as a resource, because it lists the resources that I talked about before. Next slide. So this is the resource that MSF just produced, and it still says draft because it's still in the process of actually being written. This was presented at a meeting that I attended on NCDs and humanitarian emergencies in London last year. I think it's a great resource. It's obviously is looking at evidence on NCDs. So basically hypertension, diabetes, cardiovascular disease, renal disease, hypothyroidism, mental illness, but also neurologic conditions. I would also highly recommend these guidelines because they're not just clinical guidelines, they also provide guidelines on programmatic interventions. Next slide. So as part of the MSF guidelines, it kind of divides things in terms of what you need to do, what you need to prioritize during the first 3 months. So really looking at clinical management and stabilization for patients that have NCDs, but also they also recommend, obviously setting up referral systems for people that have either complications or that have acute exacerbations of their condition. Somebody that has a COPD exacerbation or an asthma exacerbation, how do you refer them when you don't have enough resources to treat them, as part of your health program? So these are other recommendations that they include as part of, as part of a program that you want to prioritize in the first 3 months of an intervention. So this is really looking at acute onset disaster. What do you do during the first 3 months? Again, highly recommend reading this resource, reading these guidelines. It provides a lot of really good information, and I won't go through everything. Next slide. And again, I mentioned SPHERE guidelines, so minimum standards in health action that now includes a portion on NCDs. I won't go into it in a lot of detail, and I also highly recommend looking at it. Next slide. So here is a section from SPHERE, kind of explaining why there's an increase in NCDs in countries that are low and middle income. So basically, as I mentioned before, population aging, an increase in life expectancy has really shifted looking at the epidemiology, there's been this transition, as I talked about in the introduction, from communicable diseases to non-communicable diseases, and how in the setting of a disaster, really NCDs are becoming a major health problem. And so really the goal is to reduce morbidity and mortality during an emergency. And so it provides, guidance on how to do that. Next slide. I am now going to talk about this case study that Lance, myself, Mary Lou Fisher, Tom Wood, and a couple of others actually published last year. So we basically did this retrospective study looking at the prevalence of hypertension among patients attending clinics in the Philippines after Typhoon Haiyan. And I will describe some of the results that we found. Next slide. So on November 8, 2013, which is exactly 4 years ago, Typhoon Haiyan struck the Philippines, leading to a humanitarian emergency. SP established a field hospital in the parking lot of a hospital that was actually designated or assigned to us by the Filipino Department of Health. And in addition to providing support to that hospital, we conducted multiple mobile clinics that were deployed every day to very remote locations. And to your left, it basically shows you areas where we conducted mobile clinics. So basically in multiple areas across the island of Leyte. Next slide. And here are a couple of pictures. And the reason why I included these pictures was to kind of highlight some of the challenges in providing care after an emergency. So to your top right, so there's a picture of me with Lance Plyler and John Troke, who works for SP. And the hospital was completely destroyed. And imagine some of the challenges in actually trying to either find, patient records or providing services when a hospital has been destroyed. So to your bottom left, there are two pictures. One that was taken in the hallway immediately after the typhoon. And again, it just kind of shows the level of destruction. And the picture on your right was actually taken, I think, about 1 or 2 months after the typhoon. So SP helped rehabilitate this hospital. But during those first 3 months, as mentioned during, in the MSF guidelines, priority, was given to basically prevent acute exacerbations of disease, prevent complications, provide medications to patients. And so it took several months to actually rehabilitate the hospital. So top left, so you have Kelly Seitz, John Troke, and Mary Lou Fisher. We're basically looking at some of the records and trying to ensure that we had a systematic way of actually looking at the records and keeping track of who we were seeing. Bottom right, you have colleagues, some Filipino nurses that were working with us who were checking blood pressure. And we would go to various sites in the Philippines, and there were hundreds of people sometimes that would show up in a day. And some of the challenges, obviously, with mobile clinics is you're not there all the time, and there's a lot of loss to follow up. And with chronic diseases, you actually need continuity of care. So you have to have a really good record system to keep track of what patients were being prescribed, which drugs they were already on, whether or not they had side effects. Next slide, please. So as part of this study, we actually did this retrospective analysis of about 3,700 patients that we cared for that attended these mobile clinics. And the clinics were located in 40 barangays, and a barangay is essentially just a health unit. It's the smallest administrative unit in the Philippines. And the health clinics that we conducted were in various parts of the Philippines, the island of Leyte, Western and Eastern Samar, which is a different region, but also very small. So these are all island provinces within the Philippines. So when we evaluated patients as part of your typical evaluation, we did a history and physical, but also documented vital signs, which were measured but also recorded. And again, I mentioned the challenges in trying to set up a system where you're able to keep track of all of this as you're going from place to place with the high number of patients that are coming was challenging, but we actually managed to get a good system in place. Next slide, please. So we recorded blood pressures. They were entered, they were actually recorded on paper. And when we got back to our base, we were able to enter these blood pressures into an electronic patient database. In addition to that, the Filipino Department of Health required us to report specific conditions and we entered them into a form called the SPEED form, and that stands for Surveillance and Post-Extreme Emergencies and Disasters. So because we were, obviously it's good practice to keep record of everything, but in addition to that, the SPEED form really helped us track specific conditions. Next slide, please. So after entering all that data into this electronic database, we were able to analyze some of the results, some of the data, and we found that among 3,600 patients, the mean age of patients that we actually evaluated at these clinics was about 50 years with a standard deviation of 17. But 47% of all the patients we saw had a high blood pressure. So basically systolic blood pressure greater than 140 and diastolic greater than 90 millimeters of mercury. And that was quite high. So blood pressure was measured twice, once by the nurse that was basically screening them, but then if the blood pressure was high, the blood pressure was rechecked by a physician as they were being evaluated in clinic. So similar numbers between males and females, slightly higher. So 49% of all males had high blood pressure and 46% of all females had high blood pressure. There were fewer males that were actually attending our clinics. So only 986 males attended the clinic. And this was probably due to the fact that they were, busy with, work and for other reasons, potentially. Typically, you see less males attend a clinic in various countries, or there are less males that actually seek care. That's a trend that you see in a lot of different countries. Next slide, please. So when looking at stages of hypertension, we also found a lot of, actually 25% of all patients had stage 2 hypertension. And that was a little bit concerning because of the fact that, and it could be attributed to multiple things. It could be due to the fact that there are a lot of patients that did not have access to the medication for a long time. It could have been due to stress because of the emergency, but more likely due to the fact that they did not have access to treatment for many days. Next slide, please. So I'm going to briefly talk about NCDs in Syria. So Syria is a country, as I mentioned before, that has been affected by a protracted crisis. So there's been a war in Syria for 6, almost 7 years, with 11 million people displaced. And the magnitude and duration of the conflict, as well as the resulting mass displacement, has really had a profound effect on NCD care across the region. So WHO has been doing a lot of different studies, and they found that before the crisis, 79% of all deaths were actually due to NCDs. And I am not aware of a study that was done, during the crisis or after to demonstrate that this number has either stayed the same or increased. But you can make assumptions, you can make hypotheses that the number of deaths due to NCDs potentially has increased because of the fact that there has been disruption of health systems. But I wanted to give this example to contrast the one from the Philippines, where in the Philippines, we provided services for a couple of months and the health system was able to recover quite quickly. In fact, the Department of Health asked us to I wouldn't say leave necessarily, but they felt like they were able to, stand up and basically provide services after a couple of months. In Syria, with the war that's been ongoing for the past 6 years, there are more challenges in terms of providing services. And because NCDs are chronic diseases, you have to be able to provide medications for a long time. So for partners that are operating in Syria, how do you, and this is a good question, how do you provide services that are adequate for individuals that are in displacement all the time, that are affected by conflict, and that have these chronic conditions? So these are things to think about and differentiate when you're looking at an acute onset disaster like in the Philippines and a chronic/protracted crisis such as Syria or Iraq or some of these other countries like South Sudan, for example. Next slide, please. So WHO is now is actually doing this pilot study where they are providing NCD kits to countries that are in the EMER region, so in the Middle East. And for those of you who know what the IEHK kits are, these are basically kits that WHO has that provides medications for 10,000 individuals for 3 months. And they contain antibiotics, they contain antipyretics, and a variety of different drugs that are needed to actually do health programming in these regions. In various countries that are affected by a disaster. But in the past, IEHKs did not have any drugs for NCDs. So given the fact that there are more and more countries that have a high prevalence or high burden of NCDs that are affected by a disaster, WHO decided to include drugs for NCDs in these kits. And so they contain essential medicines for the management of cardiovascular disease, including hypertension, so diabetes, chronic respiratory diseases, and the management of some mental health conditions and neurological conditions. So there is, I don't know if we can play, there's a link to a YouTube video. I don't know if that can be played, but if not, you can use it as a reference and watch the video later. Next slide, please. And I briefly talked about some of the ethical issues related to providing services for NCDs during humanitarian emergencies. How do you prioritize diseases? Is cancer more important? Is hypertension more important? So people that have renal failure, do you want to focus on that? How do you decide which disease you want to prioritize? And it's really interesting because there have been a lot of conversations on whether or not you should be treating cancer during an emergency. Should that be a priority? Should you continue dialysis? And there's no right or wrong answer, but these are issues that you have to think about as we're seeing more and more programming that's focused on NCDs. In terms of level of care, so primary care is extremely important. When do you decide to go beyond primary care? And in terms of specialties, are you going to deploy cardiologists to treat, myocardial infarctions? How do you decide what type of level of care you want to support? And these are things that you have to think about because it also kind of relates to resource allocation. When you have limited resources, how do you decide whether to prioritize secondary health facilities versus primary? And these are things that are being discussed in the international/humanitarian community. And there are lots of interesting papers that actually have been published on this. And again, there is no right or wrong answer, and these questions will generate a lot of very interesting discussions, but also guidance. And so, really, do you treat somebody that has breast cancer? Do you treat somebody that has leukemia? If you have access to drugs, should that be a priority? And it would be very interesting to kind of hear about whether or not people think that cancer should be treated or people should be dialyzed. And this is, again, an ethical issue. Next slide, please. So here are references, and I included various papers that have been written recently on this issue of NCDs during emergencies. So the second one, it was written by MSF, as well as folks from the London School of Tropical Medicine and Hygiene. So again, I highly recommend reading some of these papers, reading the guidelines that I discussed previously, because I think they actually offer a lot of good insight on programming when you're setting something up after an emergency. And I believe that concludes my presentation.
Thank you so much, Dr. Linda. That was wonderful and just really good topic. It's really interesting to think about the impact that NCDs make on when you have a disaster. I think, if you haven't responded to disasters before, not a lot, your tendency is to think, oh, we send a field hospital, we're treating crush injuries, we're treating trauma, and yet, even in your experience and everything, it just, with the large amount of people that have needs just by a disrupted health system that are, might die of heart attack or hypertension because they don't have the medicines. I think it's really good that we're reviewing those guidelines and starting to think more in that manner of not just the emergency of the earthquake victim, but the broader population. I want to just remind our listening audience to post your questions in the group chat for Dr. Mabula. So if you have questions or comments, please feel free to do that. Our first question for you, Dr. Linda, is from Samantha, and she asks, when you are doing mobile medical clinics, how many days or months worth of medication would you typically give to patients, such as hypertension meds, insulin, et cetera?
It's a very good question. I think I would say it depends. It depends on access. So if you're treating a patient that is able to come back in 2 weeks or a month, to get a refill on drugs, I would say have them come back. But it really depends on how often you're going to be doing mobile medical clinics in the area. So the answer is it depends on, number one, access. It depends on whether or not you're going back. It depends on whether or not the clinic that this patient is able to go to is going to be restored in the next couple of weeks. So typically, I would say 2 weeks to a month, but again, I would ask specific questions about access to care. And again, with medications like insulin, there's a high risk of, hypoglycemia associated with the administration of insulin. So you want to make sure that patients have access to a, glucometer. But if they don't, then you have to use your best judgment in determining how much insulin you want to give them, what the dose is going to be. Do they have access to food? These are things to consider as you're administering insulin. So I think there are lots of questions that you would need to ask that patient, and you would have to think about the factors that I described. But I would say typically 2 weeks to a month supply for those drugs, I think would be ideal. But if you're not going to be coming back to that area and you feel that the patient is sufficiently educated, knows what to do if they develop side effects, then I would actually give more than a month supply. You can give a 2-month supply if they're actually stable and they don't need follow-up. But if you feel like they need to be monitored or need a follow-up visit, I would give about a month. So really use your best judgment and based on factors I described, like access to other health facilities or access to care.
Thank you. Any other questions for anybody that they would like to post for us? We'd love to hear from you. Dr. Linda, can you tell us in the NCD kits, how many people are they supposed to treat? I know you said they're like the IHK kits. Is it supposed to treat a certain number, and how have they kind of determined what goes in there and how many people and how long?
Sure. So I can send you an article that describes how they came up with the content of the kit. So which drugs are in the kit. So they have, beta blockers, ACE inhibitors. I believe there's insulin in there, metformin, et cetera. But there's an article that was written by one of the health advisors from WHO, Slim Salma. And he actually published an article in the Lancet that describes kind of the rationale in choosing specific drugs. And I can send that to you. But I believe that the idea was to actually treat 10,000 patients for 3 months, such as is the case with the IHKs.
Sure. And would they include glucometers then if you're treating diabetes?
I believe they also have certain supplies like glucometers, and I can send you actually the content of the kit as well. I believe the video on YouTube describes what's in the kit as well. So I can send the Lancet article that talks about the rationale, as well as an Excel file that has the content of the kit. And I think watching the YouTube video will also kind of provide a little bit of insight into the NCD kits that they're using.
That would be great. I think that, it would be great to look at that. And we will send that out in our follow-up email. We can send out those references and the link to the video, and also the article if you send that to us. Dr. Mabula will make sure that we send that out to our email subscribers, I guess you would call it. If there are no more questions, I just want to thank you so much, Dr. Linda, for just a great presentation. I think the content was really applicable, and I certainly learned a lot, and I'm sure our viewers did as well. I want to remind people again about the CME to fill that out if you would like credit for it. The directions will be in the follow-up email. Our next webinar will be Wednesday, December 13th with Barbara Rash. She has worked in our field hospital in the laboratory, and she is going to be speaking on laboratory work in the emergency field hospital. So it's sure to be a great presentation. So I hope you are able to join us then. Thank you again for joining us, and thank you, Dr. Mabula, for the great presentation.
Thank you, Beth. Bye, everybody.
Bye.